It's a great pleasure for me to come here. This is my fourth time, and I know some of you from Antalya also. You visited as a student with Erasmus. I'm really familiar to all of you. Thank you. It's a great pleasure. I thank the organizing committee and special thanks to Professor Kotoi. And I would like to thank Marta. As always, she opened my paths. She fixed all the technical problems, and I'm going from her path. Today, we will talk about kidney, but not non-tumoral ones. I will just like what I am doing in routine, I will share with you. Is there any nephrologist here? Oh, great. You know, the physicians are from another planet. Not from our planet, the pathology planet, but I know that nephrologists are sometimes visiting pathology planet. That's why I would like to thank. It's really easy to work with a nephrologist if you are a nephropathologist because they are very familiar to the pathology of kidney. What we do in medical biopsies, of course, in all sections, it's really complicated, but kidney biopsies are really complicated. We need a deep clinical information. All laboratory we need usually. That's why we also have a WhatsApp group with the nephrologists, adults and pediatric ones, and we have a really good friend from nephrology department. And what's the clinical, to learn the clinical information easily? Of course, we have a microscopy also. It's a different microscopy. Grossing is a bit different in kidney biopsies. I will share what I am doing in routine. And we are looking at the microscopy, but we have lots of sections. The light microscopy, histochemistry, immunohistochemistry, immunofluorescence, and electron microscopy. And nowadays, all over the world, we are working mass spectrometry for the kidney biopsies also. We need these are the ancillary tests we are using, and diagnosis. We usually prefer in kidney biopsies, if it is transplant or medical, it doesn't matter. We need a synoptic reporting. It's very important because we are giving some data for follow-up the patients. That's why we need also not only the diagnosis, we need also clinical correlation in comments. That's why it's not easy usually. We have long reports. That's what I want to point out, synoptic reporting. We have a checklist usually. But we are in this step, unfortunately, in our university. We cannot do this binding with this Sinomet code because of the system, automation system. We're working on it. The Sinomet coding is really important for synoptic reporting of the kidney biopsies. It's like a flower. You need very ancillary tests, and you finally reach the diagnosis, but it is kind of, journey for a nephropathologist to work on a kidney biopsies. What we do for the techniques that we are using for the kidney biopsies are, the most important part is fresh kidney biopsies. We dissecate it under the microscope to evaluate if it is adequate for evaluation. I will show what I am doing. In light microscopy, we have low power magnificence and high power magnificence. We use all of the parts. Usually, the grossing is easier than reporting the kidney biopsies. Usually, my residents prefer to leave them at the end and want some coffee and some sweet things because it takes a bit long. In histochemistry, we usually prefer PAS, Mason trichrome, plasmethylamine silver, Congoret, toluidine blue methods. In immunohistochemistry, C4D, amyloid A, NAL1, and PLAR2R is used usually in our routine. In immunofluorescein, some people have C4D also in immunofluorescein, but we don't have. But I'm unfortunately don't have in my department albumin, but we need also albumin. Unfortunately, in our institution, we don't have. This is my routine. They brought from the biopsy center the fresh tissue here in saline buffered, phosphor buffered saline, sorry, it's vice versa in Turkish, that's why it's not easy for me to translate. We put the fresh tissue here and look under the microscope and count. Usually we prefer, according to the pre-diagnosis, we prefer it changed 6 to 10 for light microscopy from the fresh tissue. But if they are thinking FSGS, focal segmental glomerulosclerosis, we need a bit more, but it's up to the situation of the clinic of the patient. Sometimes we don't have that opportunity, but if we have, we want a second biopsy or third biopsy for the patient. In microscopy, without staining, you see the glomerulus. We are counting that. The capillaries here. But sometimes it's not easy. I will talk about the pathologies. If there's a, for example, membranoproliferative, collapsing of the capillaries, or global sclerosis, we cannot sometimes count the glomerulus. That's why we can say that it's not adequate, but at the end we see maybe more than 0.5%, 50% global sclerosis, then we have the diagnosis. That's the histologic patterns can change, can change our procedure during the evaluation of the kidney biopsies. The important point in kidney biopsies, we usually give a pattern. We have to make it correlation to the clinic. Some clinical pathologies have the same pattern in kidney biopsies. That's why we need also ancillary tests. Although we have ancillary tests, we still need the serology of the patient during we diagnose the kidney biopsies. Usually I talk with my residents, if you like, puzzles, because the nephrologists are real puzzle lovers, because we have to integrate many things while we are evaluating kidney biopsies: the clinical information, laboratory data, morphology, immunopathology to reach the better diagnosis. Before pathology, we have to talk about histology. We have to know where we are looking, according to the pre-diagnosis, where we should look for. That's why I usually start my lectures with histology of the kidney, histologic anatomy of the kidney, I would like to say. It's not like placenta. Placenta have gross findings, and you can correlate to the microscopy according to the places, localization. But in kidney, you don't have this chance. You have to know that if you are in the cortical part or in the medullary part. Usually it's cortical part, because for medullary biopsies, there's a risk of hemorrhage, hematoma for the patients, and usually we are looking for glomerular diseases. That's why we need glomerulus in the cortex of the patient. Just in case, if we are talking about tubular interstitial lesions, or we are looking the transplant cases of antibody-mediated rejection, we also need a bit medullary part to be sure about the situation. Here, the glomerular part and tubular part. In tubules, if they are a bit eosinophilic, they are the proximal tubules, and distal tubules are clear, cubic shaped, sometimes more smaller than the others, the proximal one. And in glomerulus, there are lots of compartments. Usually, during the final exam of pathology residency, I prefer to ask these questions, because it's also easy but sometimes not. It can be challenging because they found it very easy not to work on or not to talk on, but it's really important because you are explaining the pattern, the pathology, elementary lesions according to the localization. We are talking about the renal corpuscle. It's consisting of glomerulus, Bowman space, and Bowman capsule. And the cells, what are the cells? We have to call the parietal cells. We will use this terminology in many elementary findings of the kidney biopsies. This is the vascular pole, and this is the urinary pole, and you see mesangial cells here, and these are the podocytes, and these are the capillaries, and this part is macula densa and juxtaglomerular cells over there. In a normal glomerule, we see in 200 microns, usually. The glomerular tufts consist of 3 cells. These are mesangial cells, endothelial cells here. These are the podocytes. This is the Bowman capsule. And you see here the parietal cells. And this is the arteriolar area. And here, glomerular basement membrane along the capillaries. Now, finally, we finished the histology part, and we are starting about elementary lesions. The most important thing, we are usually talking about hypercellularity and enlargement of the matrix, increasing of the matrix. What we are saying is just, if we are saying hypercellularity, usually, as usual, in the capillary loops, we have to see 3, or less than 3 or less cells, mesangial cells. But as here, if you see 3 or more in the 2 micron thick tissue, it's, I know it's different from the routine. We need a thinner one from the routine for kidney biopsies. Here you see there are more than 3 each capillary loop cells. That's why we call it hypercellular. But if you have a thicker, your technicians don't want in routine to take 2 micron thickness. If you have 3 or 4, you have to think about 4 or more nuclei for hypercellularity of the capillary loops. And there's another terminology called focal segmental sclerosis. It's the name, it's very clear. The lesions are focal, not all the glomerules, but some of the glomerules are affected, and not the whole part of the glomerule is affected, just you see it segmentally. As is here, it can be like here this part, periheliar variant. You see the collagen, this is silver staining. Collagen is sedimented here. Is it true, Marta? Segmental sclerosis, but the silver staining is intense staining there, positive. It's all positive, but it's not amorph here. It's amorph because of the sclerosis, it's staining collagen. And the other part is usually tip lesion. Here, it's opposite part. It's the urinary pole of the kidney, glomerule, and you see here the sclerosis. I think this is not a sclerosis. Maybe from the far away I mixed it. This is the periheliar variant because here you see the hilar area and just according to less than half. And this is not periheliar, but you don't understand, you cannot specify it. It's the lesion is focal segmental sclerosis here. And this is the collapsing variant. You see the visceral epithels, and here the collagenosis and sclerosis. This is the membrane proliferative pattern. You see mesangial hypercellularity. I think this is a thick one. We have more than four here. And the matrix is eosinophilic one, it's increased. And as you see do you remember from the fresh tissue? We saw the capillaries, erythrocytes. For this case, you know, the capillary loops are invisible. Then we cannot see in the fresh tissue also, in this case, the glomerulus usually. Another important injury finding is crescents. Usually if we see crescents, it's an emergency diagnosis for us. We call our colleagues from nephrology. We see crescents. There's a necrose or not. It's necrotic or non-necrotic because they immediately start their therapy for the cases. What we see the 2 or more layers of proliferation in Bowman space here. As you see here, it's a huge one. It's the hallmark of severe injury of the kidney and glomerulus. In the crescent pathogenesis, it's a rupture of capillaries due to protein passage. Usually, severe proteinuria may make crescentic diseases, and also the systemic diseases can cause a crescentic pathology in kidney. Here, these are cellular ones. You know, this is Masson trichrome. We can see the fibrosis here and collagen. And this is phosphomethylamine silver. It's a silver staining. You see here the crescents. We don't see any black areas, silver staining areas. And here also the blue areas are the collagen, as here in the Bowman capsule. But in crescent, we don't see any bluish appearance. It means that these are cellular crescents. Why the cellular crescents are important? Because it's really acute. You immediately make a therapy. Usually it's steroids, I guess. If it doesn't solve, you use immunosuppressive, I guess. But we have to call. We have a button in our system. It's an emergency diagnosis. Before reporting it's a pre-diagnosis, we have a crescentic case, and it's cellular. And here you see the black parts and these cellular parts. It means that this is a fibroepithelial. It's fibrocellular, or we call it both. We have a crescent with fibrocellular appearance, and here this is fibrous. It means that we are a bit late. If it's too much, it's really near to failure, chronic renal failure, unfortunately, and very close to transplantation. And another finding for crescentic thing, an elementary finding, is necrosis. Usually we see it's not like a palisatic necrosis in other cases. It's just fibrinoid necrosis because it's a capillary area, and we see some chirorrhexis. And the most popular one is double contour tram track. Here, I have to be a bit close here. Here, double track, it's really good here. This is the popular one in membranoproliferative glomerulonephritis, and also in transplant glomerulopathy, we see this double tram track. And this is the summary of our elementary lesions. And we have to use immunofluorescein also. In immunofluorescein, we have to remember the histologic anatomy of the kidney, and we have to look where it is staining. The staining area is very important for us. For example, here, it's a mesangial staining. And here, this is in the capillary walls. When we look here, there are some, I guess, they are like not, it's mesangial, but not like this. And it's like segmental, not whole of the glomerulus. And these are global but semi-lunar staining. And we here see mesangial staining again, and diffuse staining of the capillary loops, again smuggy-like, and there are some intracytoplasmic stainings here. I know it's not easy. Just, we are looking, but just this is the beginning, you have to think about it. If it is, sometimes it's very difficult for us also to differentiate it. Here you see, this is anti-GBM disease. It's linear in the GBM, glomerular basement membrane, but also it's linear here, but it's in the capillary loop wall. It's unfortunately challenging for us also. Then we ask our nephrologists, does the patient have diabetes or something like that? In electron microscope, we see the higher magnification of the organelles also. We have to find the glomerules. It's usually hard if you don't have an automatic one to find out the glomerule. We have to find the glomerule, and we have to find the GBM, endothelium, epithelial cells, urinary space, lumen of the capillary loop, and in the lumen we have to evaluate how many cells, what cells are in the lumen of the capillary loop. And the thickness is important, podocytes are important, the fenesters are important. Just we have to know the histology first, electron microscopic histology. And also we have some pathways, the algorithms that we are looking for. If you see a normal glomerulus in light microscopy, you have to know if it's a nephrotic syndrome or it's a nephrotic isolated hematuria. If it's isolated hematuria, you have to think of IgA nephropathy. If it is positive for immunofluorescent IgA, you call it IgA nephropathy. But if it is negative, you have to think about thin GBM, normal GBM. It's just, this means that you need electron microscopy again. If it is nephrotic syndrome, the immunofluorescence is important. If it is negative immunofluorescence, we usually think about in our routine focal segmental glomerulosclerosis. But if you have IgG positivity, C3 positivity, it means that you have membranous nephropathy, probably. But you have to, nowadays Mayo Clinic published a paper, but it's everything is getting complicated, unfortunately. In renal pathology, in primary nephrotic syndrome, we have to think about minimal change disease at first if you are looking at a child. And focal segmental glomerulosclerosis, unfortunately, rising because in the previous years, our routine was membranous nephropathy. Unfortunately, nowadays, it's becoming FSGS usually. We don't know the reason yet, but probably also there are some guilty viral things also after corona. We see more focal segmental glomerulosclerosis. We were expecting tubular interstitial diseases, but FSGS is rising. Let's talk about minimal change. Its etiology is usually idiopathic. Loss of negative charge of glomeruli is the reason. Circulating permeability factors are obtained, and virus, drug, lymphoma are sometimes guilty for the etiology. In clinic, we see nephrotic syndrome, proteinuria. In male child, it's more often than female. 90–95% of the cases are responding to the steroid, it's luckily. The fifth part, 5% usually, in our institution is 5%. Nowadays we are working on NGS. Usually they have a genetic pattern for steroid resistance. In light microscopy, it's near to normal histology. We see everything near to normal, but in electron microscopy, we see effacements of the podocytes and microvillous evolution, and here also effacements. This is more, I would like to compare with the normal one. You see the fusions of the podocytes, epithelial cells, and microvillous change here. It's called villous hypertrophy for the minimal change cases. And this is the fusion and effacement of the pedicels here. In immunofluorescence, usually it is negative, but in somehow we found out that IgA, IgM, C1q, and C3 mildly positive are steroid-resistant one also. In focal segmental glomerulosclerosis, this is one of the most common in our routine. The proteinuria is very important, and it's a nephrotic syndrome. It comes with kidney failure, unfortunately. Mesangia at the end of, when you are going to end, we see also thickening, collapse, adhesion to basement membrane of the glomerulus, mesangial matrix increasement, and occlusion in capillary lumens, and pedicle loss. It may be primary or secondary. In light microscopy, we have some clues for secondary one. If it's that interstitial inflammation and tubular interstitial effect is very apparent, we usually think of and we make a comment. At first, we are thinking of a secondary focal segmental glomerulosclerosis, but if we see only in the glomerulus the change, we usually prefer to tell the clinician, you have to look for genetic change, and it may be a primary focal segmental glomerulosclerosis. It's different in our routine, in FSGS. It should be more than 10 usually. If we want to say it is not focal segmental glomerulosclerosis. But if you see one, it's enough to say it's an FSGS. But if it's not, you couldn't see any focal segmental sclerosis, and the clinician is insisting on this is an FSGS, you say that I cannot rule out. I have to rule out with 25 glomerulus. In normal, you see 2 or 3, but here, this is a mild one. Usually we can miss this. That's why we need histochemistry. I like silver staining. In my routine, I also like silver jewelry, but here the silver staining is really good. It shows the injury areas very well and the collagen deposition. In immunofluorescence, it's usually negative, but we have to be careful because the injury areas are the chemotactic areas. All inflammatory mechanisms are migrating to that place. That's why we can see also IgM, C3, and sometimes C1q accumulation in the segmental areas of the glomerule in immunofluorescence. But the appearance is non-specific, I would like to say. That's important. In electron microscopy, if you are lucky, because this is a focal lesion, if you are lucky your glomerule is an affected one, you will see twisting and retraction of the basement membrane, subbasemental hyaline depositions, capillary lumen narrowing, occlusions, increase in the organelles, in podocytes, hypertrophy, sometimes microvilli transformation. And also erasing in the pedicels, in collapsing variant, separation from the hypertrophied podocytes basement membrane and formation of new basement membrane. I will show them. I know it's not easy, but it's important for nephropathology to hear before. while you are looking in your routine, it will be really easy for you if you heard about it. Here. This is the focal, this is normal one. This is the focal segmental. This is the thickening of the basement membrane, and there are some collagen deposits here. This is the capillary lumen, and some insudations, I guess. In focal segmental glomerulosclerosis, we have to subtype it because the prognosis is very different for each. Usually, in our routine, we see non-specific type, but if you see any collapsing lesion, you have to say it's collapsing variant of FSGS. If you don't see any collapsing elementary lesion, you have to search for any, you have tip lesion. If there is a tip lesion, you have to call it tip lesion variant. The nephrologists say, I have to believe them, the collapsing variant is a worse prognosis and tip lesion has a better prognosis, and the therapy program is different for each. You prefer in collapsing variant more tough one. If you don't see any tip lesion, any collapsing lesion, but you have endocapillary hypercellularity, it may be, if it is yes, it may be a cellular variant. If it's no, you have to search for if there is any perihilar lesion. And if it is more than perihilar lesions, half of the lesions are perihilar, you have to call it a perihilar lesion variant. If you don't find anything, you cannot specify and you call it NOS. In tip lesions, here, this is the entrance of this is the vascular pole, and this is the opposite side. You see some foamy cells. Yes, it is. They are foamy cells in tip lesions in the urinary pole of the glomerule. And this is like a ribbon-like thickening of the basement membrane, GBM, here. And another pathology, it was the descending one, usually in our routine, but I didn't, it's not published like this in the literature, but we see less membranous nephropathy in our routine now. The nephrotic proteinuria is the clinical finding, and unfortunately, 1/3 of the cases go to end-stage kidney. That's why they need usually transplantation. This is very fancy for membranous nephropathy, the silver staining. I would like to put it the same because they are like yin-yang. Because these areas, not black ones, are here brown. Because this is the immune complex, just on the GBM, just like small nodules. It's like pearl-like nodules. That's why it's fancy. And, sorry, these are the spikes. But these spikes are the collagen. The empty places are the immune complexes. And these spikes are between those nodules. That's why we see like that. We can C4D and NEL1 and PLAR2. R is very important for us. In routine, the most common one is PLA2R, but you can see it in different expressions. You have to be careful. You can miss these cases. And also for these cases, it's not easy to find out in immunofluorescence. They may be really one positive, or it may be really not easy to. NEL1 is another, but they have the same staining pattern, also C4D. In immunofluorescence, you see this is a direct immunochemistry, I can like to say. It's a fluorescein based. You see the nodules, pearl-like, lined by the GBM. And you see in electron microscopy that dense deposits. This is the collagen, that's why you see the spikes. This is the electron microscopy findings of the membranous nephropathy. And membranoproliferative glomerulonephritis is another, it's not common, that's really good for us. You see the cellularity and matrix enlargement. In electron microscopy, there are some, we see that's why the cells are making transposition, that's why we see the double track. But nowadays, this is, I mixed the, sorry. I mixed this is for membranous nephropathy. The Mayo Clinic published a univ. We have to subclassify the membranous nephropathy to many. We need more immunohistochemistry in our panel now. And the most, how can I say, the worst one, I think, the crescentic glomerulonephritis, unfortunately. In pediatric patients, we unfortunately have more than the others. Also, it may be on after the infectious diseases, unfortunately. And it's a rapidly progressing one. Crescents are proliferating of epithelial cells, lining Bowman capsule and infiltrating macrophages. This is then after the injury, the effect of the inflammation. As in other diseases also. There are many types in type 1. This is a clinical typing. We say another thing because we are from different planets with the physicians, that's why. Type 1 is anti-GBM disease. There is a linear deposition I saw in immunofluorescein. Type 2, immune complex mediated one. Type 3, pauci-immune. It's important because in immunofluorescein we usually don't see anything. In type 4, combination of type 1 and type 3. Type 5 is ANCA negative, pauci-immune renal vasculitis. Unfortunately, we started to see one of them. But in our routine, we don't say these types, we say what we see. If it is focal, less than 50%, we call it focal crescentic glomerulopathy. If it is more than half, we call it crescentic glomerulopathy. If it is necrotic or non-necrotic, we also note it if it is necrotic or non-necrotic. And we also note if it is cellular, fibrocellular, or sclerotic crescents. The other part, mixed. All of them are less than 50%. If more than half is global sclerotic, then it means that it's going to end stage or it is end stage. We call it sclerotic glomerulopathy. We also use for glomerular crescents the immunofluorescein, if it is negative or positive, or is there a granular disease-specific immunofluorescein findings. This is the electron microscopy of the rupture in the GBM, and this is what everything starts with injury. And this is epithelial, cellular crescent, fibroepithelial, and fibrous crescent. Differential diagnosis is very large. Systemic diseases also make crescents. That's why it's not easy for us to differentiate this. We use usually big algorithms and we look many cases, but we are luckily, if you have a connection with nephrologist, it's more easy for you. I have an example case. This is the baby, 2 years, 10 months, male, and he came to another hospital with vomiting and diarrhea 2 days ago. And they found out that BUN is raised and creatine is raised, and they were thinking acute renal failure, and they referred to our hospital because our hospital has an intensive care unit, and also pediatric nephrology and pediatric pathology, nephropathology departments are present. That's why they refer to our department. When we see, we cannot see the capillary loops, erythrocytes you see here. And there are some, it's very crowded, the glomerulus. We usually prefer that there are more spaces in glomerulus. But you see here, the crescents. And there are some chirorexis, I guess. And there is the fibrinoid necrosis here. And it's saying what the pattern is to me. I don't have to just make a diagnosis. The biopsy is saying me. The crescents, cellular crescents. In this point, when I see H&E, I called my colleague. This is a necrotizing crescentic glomerulonephritis. You can do what you want to do, but I will diagnose it later. And this is with PAS. There are some tubular dilation. Maybe there are some erythrocytes in. This may have an sediment in the urinary fluid. And also, hematuria, you're right. And also, they can see some sediments. Activation of the case, it means. This is PAS. You see the parietal cell proliferation crescent. In light microscopy, we saw 12 glomerulus, and we didn't see any glomerular sclerosis, segmental sclerosis. The 8 of them were crescents. Cellular, epithelial one. This is an active lesion, and we saw necrosis and PMNL, nuclear debris in the glomerulus. In immunofluorescence, everything was negative. It's kind of post-immune. Here. But this is a baby. We call it necrotizing crescentic glomerulonephritis. It can be a post-immune, but it can be a post-infectious glomerulonephritis. That's why the clinic is very important for this case. This is an old one, adult, 54. It's also proteinuria. In 2 times, unluckily, had an inadequate kidney biopsy. Usually, they saw the medullary infiltration of the cases, chronic tubular interstitial nephritis or something. It's just a suggestion from another department, another institute. 1 week ago, the patient came with hematuria. The clinic is changing. Not it's a tubular interstitial pathology. When we see again, it's very crowded in the glomerulus. Here, the glomerulus are hypercellular, and the matrix is enlarged. Here, this is the entrance of this is the vascular pole, and this is the urinary pole. There's a segmental sclerosis with the proliferative pattern. But here, we see crescents for this case. And another finding, eosinophils. I'm not sure if they are seeing well. It's rare eosinophils. It's very important for us in tubular interstitial tissue if you see eosinophils. And here is the crescent. We didn't see any necrosis. It's cellular and fibrocellular crescents. And with the silver staining you see here, the cellular crescents. In light microscopy, we see 12, 4 crescents, less than half. And 3 cellular, 1 fibrocellular, thick tram tract appearance. Mesangial cellularity is severe. We didn't see any necrosis, and immunofluorescence is negative. And we call it focal crescentic glomerulonephritis. ANCA positive post-immune renal vasculitis, ANCA negative post-immune renal vasculitis, or drug-induced, because we saw eosinophils. When detailed clinical review was done, they found out this hematuria started after amoxicillin clonal usage. They stopped the antibiotics, and changed the antibiotics, and clinic improved. I think my time is up. I would like to thank you. I have a diabetic nephropathy. I would like to just show you Kimmel-Wilson and arteriolar hyalinosis. This is interesting because it's a renal transplant case, but the primary of the case was diabetic nephropathy. It wasn't a rejection. And we see one tubule epithelium positive CV-SV40 for polyomavirus. It's late because it's we don't expect it after 5 or 6 years, but for this case we found out one cell, and this is a recent case. They are going for PCR for this case. For also diabetic nephropathy recurrence and also polyomavirus nephropathy in a transplant patient. I would like to thank all my colleagues. You see here, I'm also one of the members of the university. I'm really happy to be here. Thank you for everything.